Welcome to our review of the BCSC glaucoma section. In this part of the series, we'll be focusing on Chapter 9, which covers primary angle-closure glaucoma. This chapter builds on the foundations we've already studied, but shifts our attention to the unique mechanisms, risk factors, and clinical presentations of angle-closure disease. Over the next several slides, we'll carefully walk through the pathophysiology, diagnostic considerations, and management strategies, making sure to highlight the key points that are most relevant for exams and for clinical practice. Let's quickly go through the key highlights of this chapter. Primary angle-closure disease is an important cause of glaucoma worldwide, and its prevalence is particularly high in Asian populations. The most common underlying mechanism is pupillary block, although other anatomic factors, such as plateau iris configuration and lens-related changes, can also play a role. Because of this variability, performing gonioscopy is essential in all patients with suspected glaucoma or those who appear to have narrow angles. This is especially true for hyperopic eyes and older phakic patients, where the risk of angle closure is greater. Treatment is always individualized and may include medical therapy, laser iridotomy or iridoplasty, and in select cases, surgical options such as lensectomy. Primary angle closure occurs when the peripheral iris mechanically blocks the trabecular meshwork, preventing aqueous outflow. This obstruction may result from direct iridotrabecular contact or from the development of PAS. When this process leads to clinical consequences, we refer to it as angle closure disease. This disease spectrum includes the presence of PAS, ocular hypertension with angle closure, acute attacks of primary angle closure, or the development of glaucomatous optic neuropathy due to prolonged angle closure. There are two broad categories. Primary angle closure results from anatomic predisposition alone without any secondary trigger. In contrast, secondary angle closure develops when an identifiable pathology initiates closure, such as an intumescent lens, iris neovascularization, chronic inflammation, endothelial migration, or epithelial ingrowth. These secondary causes will be discussed in more detail in the following chapter, but here our focus will remain on primary angle closure. To better classify primary angle closure disease, it's helpful to think of it as a spectrum. At the earliest stage, we have the primary angle closure suspect, or PACS. This is defined by at least 180 degrees of iridotrabecular contact, but without evidence of trabecular meshwork damage or optic nerve involvement. If that same degree of angle contact is accompanied by elevated intraocular pressure or the formation of peripheral anterior synechia, then the patient meets criteria for primary angle closure, or PAC. At this stage, optic nerve damage is still absent. Finally, when angle closure results in damage to the optic nerve, we use the term primary angle-closure glaucoma, or PACG. In other words, PACG is simply primary angle closure with the additional finding of glaucomatous optic neuropathy. Now that we've defined the spectrum of primary angle closure disease, it's important to recognize its global impact. In 2020, there were an estimated 23 million cases worldwide, and this number is projected to rise beyond 32 million by the year 2040. The disease shows a clear demographic pattern. Women are at higher risk, and the prevalence is greatest in certain ethnic groups, particularly Asian populations and the Inuit. By contrast, angle closure is less common among Europeans and Africans, though genetic variability within each continent leads to significant regional differences. The public health burden is especially striking in China, where angle closure glaucoma accounts for more than 90% of all glaucoma-related blindness. These statistics highlight why primary angle closure disease is such a critical focus in both prevention and management of vision loss worldwide. Angle closure disorders represent a diverse group of diseases that differ in their mechanisms, but are unified by one key feature: peripheral anterior synechiae formation, or iridotrabecular apposition. Clinically, these disorders can present along a spectrum. In the acute form, the onset is abrupt and dramatic, often bringing the patient urgently to care. In contrast, the chronic form is more insidious, sometimes progressing silently without noticeable symptoms until significant damage has occurred. When it comes to management, identifying the underlying anatomic changes and the specific pathophysiology is essential. Early diagnosis and treatment can in many cases be curative, preventing irreversible damage. For this reason, screening patients at higher risk, such as those with strong anatomic predispositions or belonging to high prevalence populations, can significantly reduce both disease burden and the risk of blindness. The hallmark of angle closure is peripheral iris apposition or adhesion to the trabecular meshwork. This contact impairs aqueous humor outflow and leads to elevated intraocular pressure. Using indentation gonioscopy, we can distinguish between appositional closure, which is transient, and synechial closure, which is permanent. Iris dynamics also play a central role. In normal eyes, iris volume actually decreases with dilation. But in eyes prone to angle closure, dilation causes a paradoxical increase in iris volume, resulting in crowding of the angle. Certain triggers for dilation can therefore precipitate attacks. These include medications, pain, emotional stress, or even sudden fright. The primary mechanism behind most cases is pupillary block, where resistance to aqueous flow at the pupil leads to bowing of the iris. However, in up to 1/3 of eyes, anatomic variations such as Plateau iris also contribute significantly. Among the various mechanisms of angle closure, pupillary block is by far the most frequent cause. The problem begins at the lens-iris interface, where the normal flow of aqueous humor is impeded. This obstruction creates a pressure gradient between the posterior and anterior chambers, causing the peripheral iris to bow forward and obstruct the trabecular meshwork. The effect is most pronounced at mid-dilation, which is why physiologic dilation can trigger acute attacks. Several risk factors increase susceptibility. Lens-related factors include a high lens vault, where the lens is positioned more anteriorly, and the progressive increase in lens thickness and volume that occurs with age. Anterior segment anatomy also plays a role. Eyes with a shallow anterior chamber depth, narrow width, smaller area, and reduced anterior chamber volume are at greater risk. Management of pupillary block is straightforward in concept. The block can be relieved by creating an alternate pathway for aqueous to flow, achieved with a peripheral iridotomy or iridectomy. This figure highlights the anatomic differences between pupillary block and Plateau iris using ultrasound biomicroscopy. On the left, image A demonstrates a classic case of pupillary block. You can see the iris bowing forward in response to the pressure gradient across the lens-iris interface, resulting in obstruction of the trabecular meshwork. On the right, image B shows Plateau iris configuration. Here, the ciliary processes are large and rotated anteriorly, pushing the peripheral iris into the angle. This leads to appositional angle closure, even though the iris may appear relatively flat centrally. Together, these images illustrate how two different mechanisms, pupillary block and Plateau iris, can both result in impaired aqueous outflow and elevated intraocular pressure. In addition to pupillary block, the iris itself can be a direct cause of angle closure. In these cases, the peripheral iris obstructs the trabecular meshwork through iridotrabecular apposition. Several mechanisms may be involved. Developmental anomalies, such as anterior cleavage abnormalities, can lead to abnormal insertion of the iris into the scleral spur, or trabecular meshwork. A thick peripheral iris may also physically roll forward into the angle during dilation, crowding the drainage pathway. Perhaps the most well-recognized variant is Plateau iris.
where anteriorly displaced and enlarged ciliary processes push the peripheral iris forward, causing angle narrowing even after a patent iridotomy has relieved pupillary block. This makes plateau iris a particularly important mechanism to recognize in clinical practice.
Medications can play an important role in precipitating angle closure in predisposed eyes. Both mydriatics and miotics are capable of triggering an event, though through very different mechanisms. Mydriatic agents, whether topical or systemic, adrenergic or anticholinergic, induce pupillary dilation. In an eye with narrow angles, dilation shifts the iris position and can provoke angle closure. On the other hand, miotics usually pull the iris away from the angle and can be protective. However, strong anticholinesterase miotics may paradoxically worsen pupillary block. They do this by increasing contact between the lens and iris, essentially pushing the entire lens-iris diaphragm forward and further narrowing the angle. A key distinction to remember here is that while mydriatics are the classic culprits for triggering acute angle closure, even miotics can be harmful in certain situations. This is why gonioscopy should always be repeated after initiating miotic therapy in patients with narrow angles.
Beyond topical drops, a wide range of systemic medications can increase the risk of angle closure in predisposed patients. Allergy and cold preparations, such as ephedrine and diphenhydramine, are common culprits. Bronchodilators like ipratropium and tiotropium may also trigger problems. Psychiatric medications are especially important to remember. These include SSRIs, such as fluoxetine and paroxetine, tricyclic antidepressants like amitriptyline and imipramine, antihistamine anxiolytics such as hydroxyzine, and phenothiazines including chlorpromazine. Other classes include urologic antispasmodics like tolterodine and oxybutynin, gastrointestinal drugs such as cimetidine and ranitidine, muscle relaxants like orphanadrine and trihexyphenidyl, and anti-nausea medications such as promethazine. A key distinction, and one that is highly testable, is that even slight mydriasis in an eye with critically narrow angles can be enough to precipitate closure. For this reason, patients at risk should always be counseled.
Race and ethnicity play a significant role in the prevalence of primary angle-closure glaucoma. Among individuals over 40, the prevalence is lowest in those of African ancestry, at about 0.1 to 0.6%, and similarly low in European-derived populations, around 0.1 to 0.4%. Rates are higher in East Asia, ranging from about 0.3 to 2.2% in Japan and 0.4 to 1.7% in China. The highest rates are seen in Inuit populations, where prevalence can reach as high as 4 to 5%. Some of these differences, such as those between white and Inuit populations, can be explained by biometric parameters like anterior chamber depth and axial length. But in East Asian populations, these biometric factors alone do not fully explain the higher prevalence. Other contributors include iris thickness and area, dynamic iris behavior, lens vault, and anterior chamber width. The overall burden of disease is greatest in Asian countries. A recent and important factor to consider is the dramatic rise in myopia prevalence in these regions, which may actually counterbalance the historic trends of high PACG burden. For exam purposes, remember this key pearl. Inuits are consistently tested as the group with the highest prevalence of angle-closure glaucoma, while Europeans and Africans are the lowest. Eyes within the primary angle-closure spectrum tend to share certain biometric features. They often have a small, crowded anterior segment combined with a short axial length. The major predisposing factors include a shallow anterior chamber, a thick or more steeply curved lens, shorter axial length, and a smaller corneal diameter or radius of curvature. Imaging has allowed us to identify additional contributors, such as increased iris thickness and area, as well as increased lens vault. Certain measurements are particularly important.
An anterior chamber depth less than 2.5 millimeters predisposes to primary angle closure. In most cases, the depth is under 2.1 millimeters, and peripheral anterior synechia are strongly correlated when the depth falls below 2.4 millimeters. It's also important to remember that angle closure is not limited to shallow chambers. Even eyes with apparently deep chambers can develop closure, most often due to plateau iris. For exam purposes, the pearl here is to link anterior chamber depth with risk. Less than 2.5 millimeters is concerning. Under 2.1 is typical for angle closure. And remember, deep chambers don't rule it out if plateau iris is present. The prevalence of angle closure rises steadily with each decade after the age of 40. The primary driver is lens-related change. The lens thickens with age and shifts forward, increasing iridolenticular contact and crowding the anterior chamber. Angle closure is rare in individuals younger than 40. When it does occur, it is usually the result of structural or developmental anomalies rather than pupillary block. Plateau iris is the most common culprit, but in rare cases, conditions like retinopathy of prematurity may contribute. Importantly, in these younger patients, pupillary block is not the typical mechanism. For exam purposes, the pearl here is simple. After 40, lens changes dominate, and pupillary block is the key driver. Under 40, angle closure is unusual and usually due to plateau iris, not lens-related mechanisms. Sex is another important risk factor for primary angle closure. The disease is 2 to 4 times more common in women than in men. Women tend to have smaller anterior segments and shorter axial lengths, both of which contribute to crowding of the anterior chamber. These anatomic differences help explain part of the disparity, but they do not fully account for why angle closure is more common in women. Other factors are likely at play, though they remain less well-defined.
Family history is another important risk factor for primary angle closure. First-degree relatives of affected patients show a markedly higher prevalence compared with the general population. Among white individuals, prevalence in relatives ranges from about 1 to 12%. In Chinese populations, having a family history increases risk by 6-fold. And in Inuit populations, the risk is about 3.5 times higher. These findings strongly support a genetic influence in primary angle closure. Genome-wide association studies confirm that inheritance is complex, with multiple loci involved and variable penetrance depending on the population.
Refractive error is another important factor in angle closure risk. The condition is most common in hyperopia, regardless of race, because these eyes are smaller with crowded anterior segments. However, angle closure can also occur in patients with significant myopia, which is why gonioscopy should always be performed, even in myopes. When a highly myopic patient develops angle closure, it usually suggests a secondary cause. Common culprits include microspherophakia, plateau iris, or phacomorphic angle closure from a thick nuclear sclerotic cataract. Even simple myopia, particularly in patients of Asian descent, may carry some risk. Although axial myopia involves posterior elongation of the globe, the anterior segment can still be anatomically predisposed to closure. While myopia and axial elongation are usually thought of as protective, it's important to remember that some myopic eyes remain at risk. Now, let's individually discuss each part of the primary angle closure spectrum, starting with primary angle closure suspect, or PACS. It is defined by the presence of at least 180 degrees of iridotrabecular contact on gonioscopy without elevated intraocular pressure, PAS, or glaucomatous optic neuropathy. The main clinical concern is the risk of progression. Some eyes will go on to develop acute angle closure crisis, primary angle closure, or even primary angle closure glaucoma. However, the natural history studies show that only a small percentage of suspects actually progress to disease. There are also diagnostic challenges. Gonioscopy has limited predictive value, even in the hands of experienced clinicians. And remember, pupillary constriction from the slit lamp light can artificially open the angle, creating a risk of missing the diagnosis.
Historically, provocative testing was used to assess the risk of angle closure and to help guide decisions about performing an iridotomy. Two common methods included pharmacologic pupillary dilation and the dark room prone position test. The ZAP study provided important insight here. It showed that the 15-minute dark room prone test was not predictive of future angle closure attacks or glaucoma development. It's worth noting that eyes with an intraocular pressure rise of 15 millimeters of mercury or more during the test were excluded. Because of these findings, provocative testing has largely fallen out of favor, and the current direction is to focus on anterior segment imaging as a more reliable predictor of angle closure disease. For exam purposes, the pearl is this. The ZAP study demonstrated that provocative testing, especially the dark room prone position test, is not predictive, and imaging is now the tool under investigation for risk stratification.
This figure demonstrates the role of anterior segment optical coherence tomography in evaluating narrow angles. In image A, we see angle closure clearly when the eye is imaged in the dark, with the iris crowding forward. In image B, the same angle appears much more open when imaged with the lights on, a reminder of how lighting conditions can dramatically change angle anatomy. Image C shows narrow angles caused by plateau iris before a laser iridotomy has been performed. And in image D, we see the same meridian after iridotomy, where the angles remain narrow, confirming that plateau iris is the underlying cause. The next slide shows a video from the AAO of the angle in dark versus light conditions in action.
In this ultrasound biomicroscopy of a patient with primary angle closure suspicion, you will see that the angle is very narrow. Upon dark room testing with the lights off, there is iridotrabecular contact. You will notice that there is anterior bowing of the iris, suggesting a pupillary block is a significant mechanism. With the room lights turned on, the iridotrabecular contact resolves, but the angle remains narrow.
Management of primary angle closure suspects begins with deciding whether or not to perform a laser peripheral iridotomy. It is reasonable to proceed with an iridotomy if PACG criteria are met, but not every patient requires one. The decision should be individualized, based on anterior chamber angle assessment, the ophthalmologist's clinical judgment, and the patient's preference. Regardless of whether iridotomy is performed, all patients with narrow angles should be counseled. They need to know the symptoms of an acute angle closure attack, understand the urgency of seeking ophthalmic evaluation if symptoms occur, and appreciate the importance of long-term periodic follow-up. The next couple of slides show the effects of LPI on narrow angles.
This UBM shows a patient with severe pupillary block, causing anterior tenting of the iris such that there is complete iridotrabecular contact. When the lights are turned off and the pupil enlarges, you see that the angle closes even more, with iris contact extending to the peripheral cornea. Notice also that the ciliary sulcus, the space between the ciliary process and the peripheral posterior iris, is open. An absent ciliary sulcus with anterior rotation of the ciliary process is typically the mechanism of plateau iris configuration, but that does not seem to be the case in this patient. In this ultrasound biomicroscopy video of the eye after laser iridotomy, you see that the anterior chamber angle is open and there's flattening of the iris. Also, the UBM is scanning through the patent iridotomy, which has relieved the pupillary block mechanism, permitting fluid to bypass from the posterior to the anterior chamber, relieving the posterior pressure which was pushing the iris forward prior to laser.
One of the major controversies in managing angle closure centers around the role of laser peripheral iridotomy. The ZAP trial showed that progression from primary angle closure suspect to either acute angle closure or primary angle-closure glaucoma was very low. Iridotomy reduced the risk of conversion to primary angle closure, but most of the eyes that converted did so because of peripheral anterior synechia formation alone, without associated ocular hypertension. Because of these findings, iridotomy is not recommended as a blanket population-level intervention, but rather as an individualized decision. It is considered when certain features are present, such as existing peripheral anterior synechia, increased trabecular meshwork pigmentation, a history of prior acute angle closure attack, a shallow anterior chamber depth under 2 mm, or a strong family history. Lens status is another factor that should be taken into account. Iridotomy is controversial in the setting of extensive peripheral anterior synechia. In those cases, it may worsen intraocular pressure and definitive surgical treatment is often required. For exam purposes, the pearl is this. The ZAP trial showed low progression in suspects, so LPI is not recommended universally, but is indicated in higher-risk eyes, especially those with PAS, prior acute attacks, shallow chambers, or strong family history. Iridoplasty is another controversial option that can be used to further widen the angle after an iridotomy. While it may provide anatomical improvement, there is no strong evidence that it prevents the onset or progression of glaucoma. The next slide shows an AAO video of this procedure being performed. Another major area of controversy is the role of lens extraction, which was studied in the EAGLE trial. This trial focused on patients over 50 years old who had primary angle closure with an intraocular pressure of 30 mm of mercury or higher, but no significant cataract. The study found that clear lens extraction lowered intraocular pressure, reduced the need for medications, and improved quality of life compared to laser iridotomy or medical therapy. Visual field progression, however, was similar between the groups.
Argon laser peripheral iridoplasty is performed with an Abraham lens, and the settings are 260 milliwatt power with a 500 micron spot size and 0.5 second duration. The spot is placed as far peripherally as possible within the view of the Abraham lens. Spots are spaced approximately 2 spot sizes away from each other, and typically about 20 to 25 spots are applied for the entire periphery. Treatment energy can be titrated so that you achieve contraction of the peripheral iris without formation of a bubble or pigment release.
Primary angle closure is defined by the presence of a narrow angle with peripheral anterior synechia, or an elevated intraocular pressure greater than 21 mm of mercury. The disease can progress in different ways. In some patients, the angle closes gradually, leading to a slow but steady rise in intraocular pressure. Importantly, trabecular meshwork damage can still occur even in the absence of synechia, simply from repeated episodes of appositional contact. The most common presentation is chronic primary angle closure. In this form, the disease progresses silently and insidiously, with gradual synechial angle closure that often remains asymptomatic until significant damage has already occurred. For exam purposes, remember the pearl. Chronic, gradual, asymptomatic synechial closure is the most common form of primary angle closure, and trabecular damage may occur even without PAS. Once primary angle closure is diagnosed, management typically centers on laser peripheral iridotomy. This is usually necessary to relieve the underlying pupillary block and to prevent additional synechial closure. However, in eyes with extensive synechia, the benefit is less clear, and there is a risk that intraocular pressure may actually rise after the procedure. If no iridotomy is performed, progressive angle closure is expected, which makes intraocular pressure control increasingly difficult over time. Even when iridotomy is done, angle closure can continue to advance, meaning that regular gonioscopic monitoring is essential. In most cases, laser iridotomy alone, or combined with ocular hypotensive medications, is sufficient to control the disease. But the EAGLE study highlights that in patients over 50 with primary angle closure and pressures at or above 30 millimeters of mercury, clear lens extraction may actually be the preferred initial treatment. Primary angle-closure glaucoma is defined as primary angle closure plus glaucomatous optic neuropathy. This means the optic nerve shows damage and there may be associated visual field loss. The disease is often insidious, so vision loss may be the first noticeable symptom. Unfortunately, it is frequently diagnosed late, which is why PACG remains a major cause of blindness in Asia. The clinical course can resemble primary open-angle glaucoma in the beginning with modest pressure elevation and no symptoms. But over time, there is progressive optic nerve damage and visual field loss, and intraocular pressure may later rise sharply, making the disease much harder to control. One key teaching point is that PACG is frequently misdiagnosed as POAG. The best way to avoid this mistake is to perform gonioscopy in all glaucoma patients. That single step ensures the diagnosis is accurate and prevents missed cases of angle closure. The management of primary angle-closure glaucoma follows the same principles as primary angle closure, with some key additions. Laser peripheral iridotomy remains the standard of care. But just like in PAC, a paradoxical rise in intraocular pressure can occur in eyes with extensive synochial closure. Medical therapy includes aqueous suppressants and outflow drugs. Among these, prostaglandin analogs are highly effective, at least as effective as beta blockers, and, importantly, their pressure-lowering effect is not dependent on the extent of synochial closure. Other outflow drugs, like Rho kinase inhibitors, may have a role, though their efficacy is not yet firmly established in PACG. Cataract surgery also plays a significant role. Removing the lens alone can reduce intraocular pressure and medication burden. In fact, as shown in the EAGLE study, clear lens extraction alone compared favorably with cataract extraction combined with other interventions, supporting its use in selected patients. Symptomatic primary angle closure occurs when there is a significant rise in intraocular pressure caused by acute or subacute blockage of most of the anterior chamber angle. Unlike the silent or chronic forms, this presentation produces clear symptoms. Patients may report pain, blurred vision, halos, headache, or nausea. This makes it a clinically important entity, as it often brings patients urgently to medical attention and highlights the need for rapid recognition and management. Subacute, or intermittent, primary angle closure presents with milder, transient episodes of blurred vision, halos, and mild ocular pain associated with temporary rises in intraocular pressure. These episodes often resolve spontaneously, particularly during sleep when physiologic meiosis helps reopen the angle. Importantly, IOP is usually normal between attacks, and these episodes can recur anywhere from days to even years apart. Because the symptoms may mimic migraines or nonspecific headaches, patients are frequently misdiagnosed unless gonioscopy is performed. On exam, the presence of a narrow angle with or without PAS can confirm the diagnosis. Management is similar to that of PAC, with laser peripheral iridotomy often recommended. Key distinction to flag for exams. Subacute angle closure equals recurrent, self-limited episodes with normal IOP between attacks, in contrast to acute angle closure, which presents with sustained, dramatic IOP elevation and vision-threatening symptoms. Acute primary angle closure represents an ophthalmic emergency marked by a sudden, rapid rise in intraocular pressure due to abrupt trabecular blockage by the iris. Patients present with severe ocular pain, headache, blurred vision, halos, and systemic symptoms such as nausea and vomiting. The visual disturbance is largely driven by corneal epithelial edema. On exam, key signs include markedly elevated IOP, a mid-dilated, sluggish, or irregular pupil, corneal edema, episcleral and conjunctival vessel congestion, shallow anterior chamber periphery, and sometimes mild aqueous flare and cells. The definitive diagnosis of acute primary angle closure requires gonioscopic verification of angle closure. Visualization can be difficult when the cornea is edematous, but this can be improved with topical IOP-lowering medications, topical glycerin, or anterior chamber paracentesis. Dynamic gonioscopy with corneal indentation is essential, as it allows us to distinguish between appositional closure, which is reversible, and synechal closure, which is permanent. Importantly, indentation itself can be therapeutic, sometimes breaking the attack. The fellow eye almost always shows a narrow, occludable angle and should be carefully examined. If the fellow eye instead has a deep angle, secondary causes such as posterior mass, zonular insufficiency, anterior segment neovascularization, or ICE syndrome must be considered. One caution during exam is that slit lamp illumination can constrict the pupil and artificially open the angle, potentially masking the diagnosis. During an acute angle closure attack, the very high intraocular pressure places the eye at risk of several serious complications. These include glaucomatous optic nerve damage, ischemic optic neuropathy, and even retinal vascular occlusion. PAS can form rapidly, locking in permanent angle closure. The iris is also vulnerable to ischemia from the IOP spike, leading to sectoral iris atrophy and pigment release. There are several ischemic and structural sequelae that can be very useful in identifying prior acute angle closure episodes. These include pigmentary dusting on the iris surface and corneal endothelium, iris sphincter ischemia that can result in a fixed, dilated pupil, and glaucoflecken, small anterior subcapsular lens opacities caused by focal lens epithelial necrosis. These findings help us recognize both the acute risks and the long-term damage that can follow an untreated or severe acute angle closure crisis. The definitive treatment for acute primary angle closure is a laser peripheral iridotomy, which relieves pupillary block, normalizes the pressure gradient between the anterior and posterior chambers, and opens the angle. However, corneal edema may initially obscure visualization, so temporizing medications or procedures are often needed before a patent iridotomy can be created. Medical therapy plays a key role in stabilizing the patient. Miotics, such as pilocarpine, may help in mild cases, but strong miotics should be avoided. In eyes without pupillary block or with ischemic sphincter, pilocarpine may be ineffective or even harmful by worsening iris congestion. Other important agents include beta blockers, alpha-2 agonists, prostaglandin analogs, and carbonic anhydrase inhibitors, whether topical, oral, or intravenous. Hyperosmotics can also be used when needed. Adrenergic agents, however, should be avoided to prevent further dilation or ischemia. Other techniques may serve as temporizing measures. These include globe compression, dynamic gonioscopy, and even paracentesis, though care must be taken to avoid injury. Iridoplasty may help relieve acute attacks, and in resistant cases, surgical iridectomy may be required. Finally, once the cornea clears, lens extraction can also be considered as a definitive treatment option. After an acute attack, follow-up is essential. A low intraocular pressure immediately post-attack does not always mean the angle is open, since ciliary body ischemia can temporarily suppress aqueous production. For this reason, repeat gonioscopy is required to confirm angle reopening. The fellow eye also deserves close attention, since it often shares the same anatomic predisposition and is at high risk for developing acute angle closure. This risk is heightened if the episode is triggered by systemic sympathomimetic agents, such as nasal decongestants. Emotional stress from the attack may also increase sympathetic tone, leading to pupillary dilation in the fellow eye. Because of these risks, prophylactic laser peripheral iridotomy is recommended for the fellow eye if a similar narrow angle is present. Plateau iris refers to an atypical anterior chamber angle configuration that can cause angle closure, especially in younger patients. It's due to anteriorly positioned ciliary processes, which eliminates the normal ciliary sulcus that we can see on ultrasound biomicroscopy. The mechanism is that the ciliary processes physically push the peripheral iris forward, narrowing the chamber recess. This often occurs in combination with a pupillary block, and dilation makes it worse as the iris crowds the trabecular meshwork. Clinically, it can be tricky. The central anterior chamber depth looks normal, and the iris plane may appear flat. On indentation gonioscopy, you see the classic double hump sign, where the iris indents over the ciliary processes. Ultrasound biomicroscopy confirms the diagnosis. Importantly, plateau iris is easily missed if you only rely on Van Herrick or slit lamp assessment. A key distinction is terminology. Plateau iris configuration is the anatomic finding without an IOP rise on provocation, while plateau iris syndrome is when mydriasis leads to a pressure rise of 6 mm or more. Finally, peripheral anterior synechia from plateau iris begin at the Schwalbe line and extend posteriorly over the trabecular meshwork, scleral spur, and angle recess. This is the opposite pattern of synechia seen with pupillary block angle closure, which progress anteriorly from posterior adhesions. These images demonstrate classic findings of plateau iris syndrome. In image A, you can see that the iris plane looks flat, but there's a shallow angle recess indicated by the arrow. Notice that the mid-peripheral iris bows forward, which is deeper than what we typically see in pupillary block. Image B shows plateau iris after peripheral iridoplasty. Here, the angle recess is much deeper, confirming that the underlying mechanism was indeed the ciliary processes pushing the iris forward. Image C demonstrates the classic double hump sign on indentation gonioscopy. As the gonioscopy lens indents the cornea, the iris buckles over the ciliary processes, creating two humps separated by a valley. This finding is highly characteristic of plateau iris. Finally, image D shows ultrasound biomicroscopy. The peripheral iris is in contact with the trabecular meshwork at the Schwalbe line, anterior to the angle recess, confirming an anteriorly positioned ciliary body and absence of a normal ciliary sulcus. The next slide is a video by Dr. Alward demonstrating the gonioscopic appearance of plateau iris configuration.
This 76-year-old woman has a history of narrow angles. She's mildly hyperopic and had undergone laser iridotomies. On indentation, you'll notice that when we push, there's a peripheral roll in the far periphery of the iris. This is very characteristic of plateau iris syndrome. Here I am pushing, you can see corneal folds, and you can see a peripheral roll. As I let up on the pressure, the iris comes back forward, the folds go away, and the iris is again flat with a very narrow iridocorneal angle. Again, I'm pushing. Again, you see the far peripheral roll of iris. I find indentation gonioscopy to be tremendously helpful in making the diagnosis of plateau iris syndrome. Again, pushing here, corneal folds are present, and a peripheral roll in the iris. We let up, the iris returns to its normal shape. Here at higher power, again indenting, and we see the peripheral roll, and we also see the corneal folds.
When managing plateau iris, the first step is to address any pupillary block component. A laser iridotomy is usually performed, and if a cataract is present, lens extraction may also be considered. In cases of plateau iris configuration without symptoms, careful observation alone may be reasonable. If angle narrowing persists despite iridotomy, what we call plateau iris syndrome, gonioscopy follow-up becomes crucial. This condition remains a common cause of angle crowding even after LPI or cataract surgery. In select cases, combining lens extraction with endoscopic cyclophotocoagulation can deepen the angle by shrinking or rotating the ciliary processes. Therapeutically, long-term miotic therapy can be used, but it is less ideal due to side effects. A more effective approach in many patients is laser peripheral iridoplasty, which flattens and thins the peripheral iris, relieving angle crowding. Finally, all patients require ongoing surveillance. Regular gonioscopy is essential as the risk of chronic angle closure persists despite intervention. Research is ongoing to optimize long-term management strategies. Great job making it through this lecture. You've covered a lot of important material. Now, be sure to look over the practice questions at the end of this video to test your knowledge and reinforce the key concepts.